I'm just like you, and our experts are just like everyone else in this room. So it's really about ending the stigma going forward. How can we be together? What changes do we need to make in Kitsap County? What resources do we need to change in Kitsap County? And thinking out of the box to get people here. So again, I am so thankful that each of you came on a Saturday when it's super, super pretty outside, and you're just willing to have this conversation with us. So thank you. Sorry, did I take your seat? Sorry, that was just I want to thank everybody for being here today on such a beautiful Saturday. I winged it.
Do you want to come in?
No.
Awesome.
I want to be able to see.
Okay.
Thank you.
So, we do have a couple questions.
Can't hear you.
Got it. Can you hear me?
Yes.
Okay. So, first question is, so where are my, I know Keith, you're one of the people that was going to answer questions. You.
Can you raise your hand if
Yeah.
you're a panel member?
Yes, please.
So then, who's a panel member? Can you say your organization and who you are?
Yes.
With that-
So can we,
Go
perfect.
ahead.
We'll go in a circle.
My name's Keith Whitfield. I'm the program manager at Kitsap Recovery Center. I'm a licensed independent clinical social worker as well as a substance use professional. No, I think everybody can hear. I got a pretty booming voice around here.
Freestyle.
Hello. Hi, everybody. My name is Brandon Foister. I'm the Clinical Director for Volunteers of America, Western Washington. I'm a licensed mental health professional, and I was a DCR and a DMHP, if any of you know what that is, for a long time, Crisis Services Director for a while, Inpatient Services Director, so kind of worked in all different ends of the system and really passionate about suicide prevention.
You sure? Yes, yes I am. Hi everyone, my name is Amy Browning. I work for the Salish Behavioral Health Administrative Services Organization. I'm a care manager there and a licensed independent clinical social worker. I've worked in mental health, behavioral health, medical services with folks across the lifespan from littles, as we were talking about, from 4 to 104. And I'm really excited to be here and having this conversation with all of these wonderful people. And let's take a moment to appreciate the fact that we had to add more chairs into this circle,
Right.
so that we could all be here. So this isn't no one is here.
Yeah, good point. Thank you. Marlene?
Bailey. My name is Bailey Hanley. I'm working with A Mission for Michael, AMFM. We are relatively new to Washington, so we are expanding our services, opening up residential treatment facilities. We're currently partnered with Fishline, providing free mental health therapy, along with the Paulsville Fire Department CARES team, having a social worker work with them 2 days a week. So I'm very happy to be here and connect with all of you guys. Thank you.
Thank you. For you?
The next, so, again, I'm Andy Keller. I am a licensed clinical social worker. I own my own counseling agency called Calming Heart Counseling. I also am a school social worker and a mental health professional. Our other two panel members are sitting right next to each other.
I'm Phil Fernandez. I am the Director of Crisis Services with Kitsap Mental Health. I oversee the Mobile Crisis Outreach Team, the DCRs. I am a DCR. I am a mental health professional. I'm a licensed social worker in the state of Louisiana. That doesn't convert to Washington, but that's so glad to be here.
You got this.
Hi, I'm Tarsha Goodine. I work with Kitsap Mental Health. I am one of the therapists in South Kitsap, sorry. I've been with Kitsap Mental Health for 3 years. I am really, really passionate about mental health, as well as from the mental health, as well as suicide, and from the BIPOC community. I just want to bring more awareness, so we are not stigmatized and are not afraid
explain the gaps that you're seeing in the mental health field at this time? Cultural competency. Central and forum.
Readily available, accessible services for youth and their families.
Readily available, accessible services for youth and families. It's really hard. My name is Heather. I'm a high school counselor up at South Kitsap High School. I've been there 13 years, and we all know we're here because the mental health concerns are increasing, but it's really, really challenging to help provide or try to provide resources, which we all have, but then we have to say, I'm sorry, it could take up to a month to get into services, okay? Or when we have to have a student go to the hospital and they're released with a safety plan, but get into services. I know, because I've talked to many of you guys, the providers are doing some of those emergent triage and getting people into services quickly if they've discharged from a hospital, but the gap that I see is we need more licensed clinicians. So spread the word. All of your friends, go get your licensure. We need people that can serve families and kids, and so there's not that gap in time. So that's really what I'm seeing at the high school right now. The substance use is skyrocketing. So there's not enough drug and alcohol treatment and resources within our schools and at an early age. We're not talking, by the time they come to us at the high school, I'm not saying it's too late. I will never say it's too late, but it needs to start in elementary. Those preventative services need to start in the elementary because it's on the rise in the middle schools, and by the time they come to us at the high school, we're triaging, we're putting Band-Aids on, we're doing things, to be honest, as a high school counselor, that we're doing out of necessity, but maybe we don't have the training for, but we're doing the best we can.
So I want to talk about a new resource in the county. Kitsap Mental Health has just started a youth mobile crisis outreach team. It's not ongoing treatment, but it is, we will respond to wherever the youth is or the family is that calls in. We'll work to de-escalate the current crisis, do a safety plan, and then we'll stabilize for up to 2 weeks. And during that stabilization, we're trying to work to give that warm handoff. So that next day appointment is really important to us. But yes, there's some issues with finding those next day appointments. So if you know any clinicians out there that have extra openings, let us know, because we will match you up. But Youth Mobile Crisis Outreach, you get it through the VOA crisis line, the Savers Crisis line. They'll respond to where you are, even a school, hospital, a home, and we'll work to de-escalate that crisis and then give up to 2 weeks, if they agree to it, of stabilization.
Can I
And
ask?
try to do that one hand.
Can I ask a clarifying question? Because you're with Kitsap Mental Health, correct? So
Yes.
when that pass-off happens, is that only for state pay,
We work with,
or will you help link them up to a provider that may have insurance?
we will,
well?
if they have private insurance, if they allow us, right? So it's all with an agreement. We work for next day appointments with private insurance companies. We send a form to the state. We know some of these systems aren't all well put together, but the intent is a warm handoff. The intent is a next day appointment. So that's where we're trying to go, and we're working with a lot of you to make that happen. So.
Perfect.
And Philip, just to add more to that, is they cannot be in wraparound services already though to use the youth mobile.
If it's a WISE person who's receiving services through WISE, we can still respond. And then we can come right in, we respond within 2 hours. We know that the WISE clinicians are also doing that, but we will do that warm handoff to WISE even, but we can respond even to WISE. And then we'll work with them to get those services.
Thank you for clarifying, because that's not the word out in the community, so thank you for clarifying.
And it's been told, like, you got WISE, don't call mobile crisis. No,
Yes.
they can still call mobile crisis.
Okay. Eric, Robin.
We can also do the dance.
Yeah, we'll do that also.
So along with that, talking about resources that we're trying to roll out, One thing that I wanted to mention that is very popular with youth consumers is through our 988 programming. We have a crisis chat and text program, which a lot of times folks of a certain youthful demographic, they appreciate being able to text a crisis counselor as opposed to having to actually execute a phone call. That can cause a lot of anxiety with a lot of youth that are trying to work on that. And frankly, some youth do not have a safe and private space in their home to be able to make those calls, right? But in this scenario, it's not uncommon for our clinicians to be on the line texting with someone who is sitting in their living room with their family, right? But struggling, can't put those thoughts or feelings or emotions to words safely, but they're able to talk to a clinician about it. The other thing that we're trying, and that's just through 988, right? All they need to know is they can just text 988 and they will be dumped right into a chat with a counselor. The other thing that I wanted to make sure folks were aware of is through our 988 programming, we are launching a limited follow-up program, and the whole idea there is if folks come in through 988, they reach out to us, whether it's chat, text, or through our 988 crisis phone lines, we will have staff that if there's a need that comes up when they're working with the counselor, can try to execute a linkage, whether that's to a youth crisis mobile team, whether that's to outpatient services, whether it's to a organization that supports transgender youth within their own community, right? We've had that pop up not too long ago. So we're trying to think outside of the box just to make sure that we can get, because it's not all necessarily about therapy and getting folks into an outpatient clinic.
Can you also add that it's not just for youth? I think we're focusing on youth right now, but we have an entire population that's not just youth that are impacted, like our older adults, we have veterans, we have adults and in general, and so VOA can be used for everyone. Can you speak to that, please?
You bet. Yeah, we have programming from across the spectrum. Speaking of which, I have my colleague Clarissa here that I'm going to put on the spot because she was kind enough to come with us. She's with our Tribal Behavioral Health Hub. We have our Native and Strong Lifeline, which is just kind of in broad strokes, it's Native clinicians helping Native consumers, self-identified Native consumers, and it's an amazing program. It's getting out there. We work with folks all across demographics, age spectrum, gender spectrums. For us, the whole idea is we just want to be there for whoever needs the services at that point in time. Right? No wrong door.
Do you want to say something more about your program? Since Brandon just put you on the spot, I would love it, and I think all of us would.
My name is Clarissa Young-Weiser. I am the Tribal Hub Coordinator for the Washington Indian Behavioral Health Hub. In our program, we are working hard to collect data and resources for everybody. There's, in tribes, there's people who can be enrolled in their tribe and can't be enrolled in their tribe, and it sets apart the services. So we are out scouring for resources that works for everybody, and I think that's all I have.
Thank you.
I have two questions. So in November of last year, I attended a parent meeting at North Kitsap High School, and one of the parents that I interpreted for was afraid that their child was going to commit suicide because of the racial bullying that he was experiencing. And in February, there was a child that committed suicide from the same school that this child attended. And the North Kitsap Latino community were very concerned because they didn't know whether it was this one child that the mom had identified at that meeting. And so my first question is, are you connecting with the schools to ensure that when stories like that are shared, that they are connected to someone to process that trauma and that fear? And then my second question relates to an incident a few weeks ago where a North Kitsap High School student in Nazi regalia and a weapon did a video saying that he was going to cut some beaners. And that coincided with a shooting threat. And a lot of people didn't send their kids to school because they were afraid. do you get involved in situations like that to do outreach to the families, especially the ones that don't have the language or the resources to know that these services are available for them and their kids?
We will talk. I mean, Kitsap Mental Health would respond. The Youth Mobile Crisis Team would respond. And I guess this team just started in March, so it's a new team. We're going to schools. We're talking to schools right now to offer that support. But again, if you hear it in your community, give them the Salish Regional line. Let them call that line. And then the other thing we're doing is we are going to high schools. So please reach out to me, get my card, and we can schedule to come to your school and talk to your counselors and teachers about our services, but yes, we would be available to work with you and your community, and so.
Did that answer your questions? Okay. I'm gonna have also the VHO and VOA just add more to it, just so you're aware of the resources available. And anybody can call these lines. If there's a parent concern, if there's staff concern, if I'm a clinician, anybody can call. So just know that's an option. And this is part of why we're doing these things, is to have schools more involved, have the community more involved, and really make a difference on ending the stigmatism, but also I don't want any of our youth or anybody to pass away or in their life and feel like that was the only choice. And then you.
So a question came up, which is something that pops up a lot, and so I just wanted to add another layer to it, which is, so we do have, you'll hear us using a lot of numbers here today for crisis interchangeably, or seemingly interchangeably, but there are differences. I just wanted to kind of sketch those out for you guys. So our regional crisis lines, which are the 1-800 numbers that we've been talking about to be able to access the team over at KMH, the difference there is the majority of the calls that we get through our regional crisis lines are going to be third parties, family members, people calling us from in the community that are saying, hey, you know, my neighbor, my friend, my relative, I'm really concerned about them and I don't know what to do. Whereas the push with 988 specifically is around suicide prevention, and we're wanting to, though the vast bulk of our calls through 988 are with the consumer directly, right? So say that kid in this scenario that the family's worried about needs someone to talk to and an ally in that moment, 988, right? Because it's smaller, it's easier to remember, you know, the person's in crisis, right? Our brains tend to not work really well, especially with numbers when we're in crisis. And so 988 is just, it's like an alternative to 911, right? For someone who just wants to talk to somebody directly. Whereas with our local crisis lines, they know a lot about the DCRs, they know what DCR cases roughly look like, they know how to get a hold of Phil and his team, and they know those level of resources out there in the community.
I actually am going to ask another question of the providers in the room around language access, which I heard you saying. Can we speak to language access for mobile crisis outreach services, 988, and anybody else who is offering linguistically and culturally appropriate services?
Yes, we have access to interpreters 24/7. We can do it all the time. Something else I want to talk about, just talk a little bit about the system. So we're saying the first piece would be to call the 988 or the Salish crisis line. Both of those lines are staffed by mental health professionals, right? They have professionals on the phone that will talk to you. And it's kind of like, what are you asking for when you do that? If you ask to get the Youth Mobile Crisis Outreach team involved, what that team is, there's levels, and we talk about DCRs, but what Mobile Crisis Outreach is about a mental health professional and a peer. So all of our teams are mental health professionals and peers. And that peer is that person that a lot of time can connect with the youth or someone who's been through our systems. And it's been a wonderful add to every one of our teams. So that team is 24/7. They come out. They try to de-escalate. If there's a need for what we call to activate the ITA, the Involuntary Treatment Act, so if you think the person is gravely disabled, danger to self, danger to others, or danger to property, then they would call in the DCR, which is the next level up from just de-escalation. to help find resources for someone who danger self, danger to others, or bring them disabled. So that's that line, and so that VOA will be that first call to try to stabilize that case, and then it raises to an outreach where we go out. And some people say, well, I called VOA and they did nothing. They do a lot. They're professionals, and they will talk to you, and then they raise it right to that next level.
Just had a really quick question. Just clarification for people around the audience that might know. Could you define what a DCR is? In case people have not heard
So designated crisis responder, it is a mental health professional, so it's somebody with the degree that lets them in the state of Washington get the certification for mental health professional. And then we, the DCRs, I'm a DCR, are vetted through the county's Salish crisis, the Salish
Behavioral
Health
Health Administrative
Administration,
Services Organization, but we can just be Salish.
Salish.
That's too many
And
letters.
so, yes, and they are, contracted through Kitsap Mental Health, and they respond for the Involuntary Treatment Act. And at one time, the system at KMH was all DCRs, and we've really moved to the mobile crisis outreach, because sometimes you don't need a DCR. You need someone to go right now, to be at the home, to be at the school, to be wherever. And that's the piece about, especially the youth, we will go anywhere, right? Wherever that youth is, we'll go to the side of the road, just where they are, because we know that's the important thing. And the other thing about the youth mobile crisis is, we really try to go without police. Because what the model is really knows is that when you bring the police involved, the law enforcement involved, it changes the discussion a lot of times. When someone's in crisis, especially a kid, they just need someone to talk to start off with, so.
And then I wanted to talk about really quickly just our language line and our interpreter services that we have. So also with us 24/7, we have access to, I don't know the exact number, but a whole plethora of languages. We serve and work with a lot of populations that are primarily Spanish speaking, or might be Russian speaking, or any of the other languages that predominate our communities here in the North Sound region and in the Salish region. So we have that available 24 hours a day. The person just needs to call in, and we can patch that in and get the language line on the call in real time. So there is no delay. It's not like we need to call the person back or anything like that, which is nice, because in the old days that's how it used to have to happen, right? But now with technology we can make that happen while they're on the call. Average length of time to be connected with interpreter services, just to let you know when someone's out on the line and they make the request, is typically around 45 seconds.
Okay, next question. What has been a positive approach or trend in our community regarding mental health awareness and education?
I think we're talking about it, right? This is a positive trend. What we're doing right now, gathering, having conversations, real honest conversations about breaking the stigma. I know I'm not on the panel, but that's just my 2 cents. It's just, I sit on enough boards and panels and active. I think just being here, showing up, having these conversations, so that now we can leave here with the resources and knowledge to share with other people, right? So the more we talk about it, I think we're getting better, but I think we still have some work to do around stigmatizing language and those conversations and ways that we can help break the stigma is to just change our own language around it and normalize it. So, but I think we're moving in that direction, especially for Kitsap County. I've been here, 16 years, and I feel like it's taken a long time, but I do think everyone is moving in the direction of wanting to do things and wanting to make change. So that's been a really positive thing to see.
I'd love to just piggyback off of that. I think some of the major changes in a positive way that I've seen is we are reaching more populations, so we're not just focusing on one population. We're really starting to look at schools, and I love the open platform of having these conversations and taking all of our community resources and taking them to schools or taking them in different areas. And I think my opportunity to work within the Paulsville Fire Department CARES team a little bit as a social worker really normalizing it in that platform, and having these conversations in different areas, whether it's schools or Kitsap Mental Health Services or Fish Line or in the fire department, I think is a positive direction that we're all going.
One thing that I did when I became director is started a group. There's a number of people in this room that are in this stakeholder group for crisis response in Kitsap County. We meet monthly. We talk about it. It's an action item group. We talk about how can we do it better. It's hosted at Kitsap Mental Health, but we have some top level executives from a lot of the different programs that are here and some that aren't here. But it's that piece of us coming together, bringing in the struggles that we're having, and then responding to that. And one of our biggest responses that we've done, we're rolling out a community-wide ROI, a release of information, because one of the things is we know between all of our programs, people touch a lot of different areas. So we need a place, and we've heard, Health has heard that we block a lot of conversations, right? Because we can't share because the way we interpret HIPAA, right? So we're trying to knock that down. We're bringing in the community ROI so that we can share, we can talk across agencies. So we're hoping to get that out by the end of the month, and I just really appreciate all of that. So.
Well, yeah, so I'm not technically part of the panel, but I work for Senior Information and Assistance with Kitsap County, so we do provide quite a bit of information and referral. And I know at least one positive trend that we've been seeing is just accessibility in general. I mean, as far as innovations such as telehealth. I mean, people that were not able to receive mental health counseling before are able to. So that's definitely one positive. It's also kind of helping us get around this labor shortage that we're presently in the middle of.
Hi everyone, my name is Shay. I'm a care coordinator at Kitsap Mental Health Services. And to piggyback off of that, telehealth has definitely been a great resource, but another positive trend that I'm seeing is just having these conversations on social media and reaching more demographics and just bridging that gap to just make sure that we're really focusing on accessibility, but also the use of apps, right? Having a coping skill that you can access on your phone when you're not able to get that, that first appointment or what have you. So I think that's been a really good positive trend that we're seeing utilized more and more.
I think a positive trend for the state of Washington was that in 2021, the legislature passed a bill, I can't remember the name of it, where they're going to be setting up a statewide advocacy program. And when you mentioned the Involuntary Internment Act and your role as a DRC, that's very triggering to me. Because in 2007 I had a pulmonary embolism, and instead of seeing my chest pain as related to a physical condition and my fainting and being confused as a physical health condition, they did an involuntary hold. And the DRC that came and spoke with me, because I was confused and disoriented, assumed that I was either on drugs or alcohol. I'm a Mormon, I don't drink coffee, I just have a headache. And that's all they did in the ER. They checked for drugs and alcohol. And that wasn't in my system. And within 24 hours, I was in the behavioral center for 3 days while suffering a pulmonary embolism, which was treated afterwards.
Well, I wanted to share, and thank you for sharing your experience. A positive trend we've seen is the growth in peer services in mental health and substance use and outreach, which has addressed both labor shortages and improved access and experience for a lot of folks.
So before I move on, I want to say I'm sorry for what you went through, and I can only imagine struggling from something that was medical and you're not able to advocate for your own needs, and then somebody with power. And as much as we use that, I was a DCR, I did it for many years. And unfortunately, we're only given so many tools. And so I'm sorry that you weren't treated the way that you should have been treated. I'm sorry that you went to a unit that probably wasn't the most effective or what you needed in that time. So I'm sorry, because I can only imagine the pain that you went through. But I appreciate that you're being vulnerable for all of us, with or without credentials, to understand that there is a need of growth and opportunity and the need to change in our community. Because yes, I practice, but not everybody practices the way that I do. I'm a social worker for a reason, right? Probably because I've been impacted. So again, I am right there with you, and I'm sorry. And this is why we are coming together for a Kitsap Suicide Awareness Coalition. To make a difference, to make a change, to really come together as a community, because we know that there are individuals like you that have had a negative impact by those that are supposed to go out and protect you and to serve to you. And I know not everybody is perfect. I know we all make mistakes. And so, again, I just appreciate your vulnerability, and I see you and I hear you, and that is one of my goals, is to really make a difference and to advocate for those that can't advocate for themselves when they're in a vulnerable situation. Philip, do you want to talk more to that, or are we on the same page?
I just echo everything you're saying, and you know, and we're not going to get into the DCR role, but you know, one thing that we do, and that's why you go to the hospital when you activate an ITA, is the need for medical clearance, and I'm very sorry that happened to you. Just very sorry.
I want to just piggyback on what everyone was talking about. So that's the need that's why I'm here today, to speak for the BIPOC community and for assumptions. You have to hire people that really love this job, that knows what they're doing, you know, not giving you your right to say, well, it's really going on. I apologize for that. My heart goes out to you. But I'm thinking the continuity of care. I'm not from Washington, but like in Missouri, we have continuity of care, and we can talk to individuals without your release of information, because all of us is in this to save your life. All of us is in this to make you successful. From the BIPOC community, that is another reason why we are scared to call VOA, and we are scared to go to the hospitals. So that's what I'm here to say.
So what needs to change, and what are the first steps?
Education, more awareness, more mental health professionals that's serious about their jobs, that care, and not just getting a job just to get a paycheck. I believe more groups like this, getting our officials involved and listening to us and really hearing us, and not just what they've been trained. So getting extra training for different officials, then getting extra training for even KMHS. All of us need extra education and extra awareness to push this. Like media looking at a person like me, or you, or a person of color, seeing us saying we need help, that says a lot. So I like the 988. I like that for our children. They, like you said, it's hard to tell somebody I'm hurting and I need help, because what we do, we shut them down. From the BIPOC community, again, I'm speaking from the perspective of that. We shut them down. We tell them, put on your bootstraps. You can do this, you know? So they're scared to come to their parents. They're scared to come to their umbrellas. They're scared to go to their pop-ups, you know? So having that is a wonderful program that we started.
just go just a little bit administrative on this question is, we need, and I've talked to state senators, they've been to KMH and looked at our crisis things. We need people, we need resources for young people to go to school to study behavioral health. I say go back to the 70s where they had grants for people to go to school, because the truth is you go into this field, you don't make enough money to pay your student loans. And again, people aren't going into the fields. We can't staff our open positions. That's why it's taken 3 weeks, 4 weeks, 5 weeks, 6 weeks to get an appointment somewhere. We need people to go into behavioral health careers. So anything you can do to raise that, it would be very beneficial. So.
Hi, I'm Lynn from Veterans Association of Real Estate Professionals. One area that we haven't talked about today too is our service members and veterans, and breaking that stigmatism from the very top leadership in our military. I have a great friend. She is a Gold Star wife, and her husband committed suicide in their garage, and he had been to finally the clinic on base and told them 6 days before that he was thinking 8 to 12 times a day about killing himself, and they sent him home. And once he committed suicide, his commanding officers telling their platoon that he was a failure and that he had failed them. So thinking of those people that are left in that platoon, and now if they're suffering. So when you talk about our congression, all those kind of things, it starts at the very top, and they need to know that it's okay, that they're not gonna lose their rank, they're not gonna be, all those things. So I think it's one area. My husband's a retired firefighter. I love, you talked about being in the fire department. It's the same thing with our first responders. They see things every single day, and they're afraid to come out. So just one area I think we need to really focus on.
So thank you for sharing that. So I'm an Army brat. My dad is a former captain in the Army, and I work very closely with our first responders. And I have seen them suicidal. I've seen them being told, we don't talk about it. You need to respond, you need to just sit down, you need to do your job, and then we're expected. And even as a social worker, I'm expected to go out to scenes of crises of somebody that just jumped off a bridge, and I'm expected to be okay. I'm not supposed to ask for help. I'm not supposed to talk about it. I'm supposed to just sit there and pretend I am Superwoman. And our first responders and military are the same. And that's not okay. And so that's the point of making sure we can raise awareness. We were supposed to have some Congress officials here. Unfortunately, they were unable to make it. They did make it to our September event. So that is a conversation, but it's also a mindset shift that we're really having to change in our military and the first responders. And it's even as males, our male population, they have been told, don't talk about it, I'm strong, you're not supposed to have feelings, you're supposed to just pull up your bootstraps and be good, right? Everybody's feelings are valid. You guys deserve to have feelings, and it's okay. It's okay to say I'm depressed and I'm struggling, and that we're here to listen. So I think this is the biggest part, is we're all human, and trying to figure out how can we change that? How can we get it up to the commander of the Navy? How can we get it to the other branches and first responders? And I know we have people in our coalition that really does advocate for that side, and that's why we try to hit all populations. I know I have more people that want to say something.
Hi, my name is Rachel Murray. I am an SEDPT counselor with Kitsap Recovery Center. One of the things that I've noticed is I've mostly worked with individuals throughout the years that experience substance use disorder, and there is a disproportionate level of female beds to male beds in inpatient settings. And so there are women that are out there waiting for services for weeks and weeks and weeks and weeks compared to the empty male beds that are out there. And I feel like one of the very important steps that we need to make is more availability for services for females that are experiencing substance use disorder.
Hi, my name is Curtis Murray. I'm an SUDP for Kitsap Recovery Center, and I'm part of a new program called the PIN program, or Person in Need program. And the point of me saying that is that one of the things that I see that my friend over here talked about we need more people doing mental health stuff, but we don't have it right now. They're not here. Okay, so perhaps we need to start looking outside of the box. We need to start looking at trying new stuff. The thing that I'm doing right now is brand new, and it's working. And just in a really quick nutshell, I'm a mobile SUDP. My job has manifested into this thing where I'm kind of a treatment fixer, and I can come out to my population is mostly homeless, but I can come out to them, meet them where they're at, and get them into detox and treatment beds. And I can do assessments on the fly if I need to. I can transport. I can do all of these things. And I've only been doing it for a very short while, but already it's starting to mushroom into something. And the reason why that I get the privilege, I get the goosebumps just talking about it every time. And the reason why it's starting I get the privilege to do this is because someone super smart decided to take a chance on something that just hasn't been tried. And it's working, right? And if we try 100 things, and what if only one of them works? Well, crap, that's one more work. That's one more thing, right? What if you only help one person? That's one more person. It's just having the boldness to step, because the things that we're doing, and I hate to be that guy in this room, but the things that we're doing and have been doing for a very long time to the same tune just aren't working.
They're not effective.
It's not, there's no, we get the same, I think it's across the entire spectrum of mental health services. We net about 10% of the people who come through our services. That's unacceptable, right? But we're just going to continue to do the same thing over and over and over again, and we're expecting different results. And in that way, we act crazy as an entire community of professionals, right? Don't we teach people not to do that because that looks unwell, right? So if you have any access to making suggestions and changes within your organizations and reaching out and trying anything different, because who knows, right? We can't, I'm partial to the substance use disorder side of this, because that's I've decided to specialize, right? But I'm looking at, I'm an addict in recovery too, so my friends and families and neighbors are out there dying, and like a whole generation is being wiped out by fentanyl, right? And so we're but we're just gonna, I want help. Call this number right here. Okay, we're gonna give you an assessment in 2 weeks. You know what? I was an addict for 30 years. When I make that phone call and you tell me 2 weeks, I'm like, I don't know if I'm gonna be alive in 2 weeks. Much less, and I'm probably busy that day anyways because I got stuff to do. And that's unacceptable. And the thing is I'm getting the privilege to do is I get to respond now, right? And it's just, yay team, right? But let's all try to figure out what else can we do differently, because again, just trying the same thing over and over, it's just not, and it's exhausting when you look at the amount of work that is necessary, right, to meet the demand, and every little piece of every little part that we all have to do, right? I know for a lot of us, I'm pretty good about self-care, but for a lot of us, we go home just burnt, exhausted, dead, tired, because we just give and give and give and give. And then we fall away from the profession. I have so many friends who used to be SUDPs who are now doing real estate and things like that because it's exhausting, right? So change the game, make it exciting again for us, so that we can continue to go out and try to make meaningful changes.
I completely agree with that, and one of the things that I think needs to change is, paying more attention to the vicarious trauma that we all experience as mental health practitioners. Yes, it's important to have more mental health professionals in our field, but how do we retain those mental health professionals if we are not giving them the support? And, you know, one thing that I've seen within our county is we've got a lot of support groups for different professionals. There's support groups for caregivers, there's, you know, all kinds of things, but where are those support groups for mental health professionals? And if we're really going to raise the stigma of seeking mental health assistance, it's gotta start with us, right? And so there shouldn't be a stigma on a counselor or a therapist receiving support for the trauma that they experience.
Hi everyone, my name is Jacob. I'm with Catholic Community Services. I am a peer partner. So one big thing that, first off, I'm terrible at speaking, so I apologize in advance. But however, adding a peer role is a very huge. Do this. Adding a peer, someone that people can talk to when they need it, someone that's been through that. Because part of the why I got into this role is because back when I was growing up, there was like 4 times that I was about to commit suicide. There was 4 times that I had a gun to my head, ready to pull the trigger. I didn't want to call someone that I didn't know, that hasn't gone through what I went through. So adding a peer role, having someone that you can call, that hey, I've been there, I've done that, I can talk to you, I can talk freely about what I've been through to help someone. So I think adding a peer role to like someone that someone can call, maybe all these agencies around here, if you add peers can really help bring the families they serve, kids, adults, anyone. So adding that role will really make people feel comfortable because, hey, I've been through, someone's been through the same as I have.
Thank you for sharing that. I think the big part of it is relating, right? We're all humans and we've all struggled and been there.
Now I gotta fire Curtis on Monday.
Right, thank God I'm tired.
Actually, and he started talking about, so we can talk about staff, right? Staff's a huge problem. We can get people, we can throw bodies in there, they're not the right folks. A lot of people go into this field to fix themselves, they're not the healthiest folks that we need to get in. I've gone through quite a few because we have a high ethical standard. As far as staff is concerned, we have to, exactly what you were speaking to, we have to take care of them, and we don't. We don't do a great job of taking care of them. We need to give them an environment because they don't get in this field to do paperwork, they get in this field to help. So we need to give them the freedom and the space to be able to do the work. As a supervisor, as a director, I spin them up and I let them loose. And I keep monitoring that and I make sure that they follow ethical guidelines, but they're out there doing the work. And then they're supported by me. And then I pay them less money than other agencies maybe, but they want to come work for me because you give them the environment that they got into the field for in the first place. That's one thing. Are we doing a good job with mental health? No. No. What do we have to do? We have to start taking risks. We have to start doing some things that are different. We have to lower the barriers for access to services. So what a novel idea. We have an inpatient with beds. Why don't I go out and offer those beds to people in need, right? Why don't we help them go find them because they have a difficult time navigating their way into services. I have a difficult time. If I get somebody that I can't manage in my facility, I can't find places to send them. So then, but you know what? Because we care, we love, and we want to help them, we end up taking the chance and trying to do it anyway. When it's sometimes above what my skill set is of my staff, because there's no place else to go. And the worst feeling that I have is putting somebody back out on the street that needs help. When we technically can do it. So there's a lot of things. We have to get out of our silos. We have to get creative. We have to start taking risks. We have to lower barriers to service, and that starts at a state level and works its way through. It shouldn't be rocket science to get signed up for Medicaid if you need it. It shouldn't be like that. And then it shouldn't be really hard when this person is mostly acute mental health and I need to get them help. I should be able to have a network of folks that I can rely on. The same way coming to me. When you call me up and say, hey, I need a detox bed and I got one, I'm gonna say yes, more often than not. I'm gonna find a way. I don't have enough space in inpatient, I'm gonna find a way because I don't wanna lose that life. And so we need to get mental health professionals in the field that have that kind of passion. And the one reason why I started, I just wanted to be a counselor, and then I saw that I couldn't make as enough of an effective change, if I was at that level, I needed to work my way up into a policy level. And then I'm gonna start to introduce ideas, and I'm gonna start to poke those into the state. And I'm gonna say, hey, guess what's working, what's not working? And I'm gonna, we're gonna start making policies. And your heart has to be in the right place. And yes, if you call me and say, I need somebody that needs help, you're gonna hear a yes more often than not. I'm gonna find a way. I'll fund you. I don't care about the paycheck. I care about your life. And that's what we need.
We've done a beautiful job of talking about taking care of our care providers and the importance of the work that we do. Another thing that I think is worth talking about is community for our folks who are in need and for everyone in general, because that's been a significant change, and is something that we can work on fostering. So treatment beyond the four walls of a locked facility, treatment beyond the room, treatment beyond the label of treatment. So, it isn't an answer but a question. How else can we build community that supports folks who are struggling, or maybe even before the struggle really sets in? And I think it is just worth reminding all of us, we as providers feel really safe in our minds when we tuck somebody into an inpatient setting. And we also need to remember that people cannot live in those settings by and large for long term. And so how do we help folks be well in the community and prevent those crises from being as acute as the level that needs to happen in a hospital or in a place where you can't leave on your own terms. There's a lot to be said for self-led help seeking rather than institutionalized help seeking.
And Brandon was.
Well, I was just going to say, one of the things that it occurs to me that I want to throw out there, because I think that there's a theme that I'm hearing with this, and it's interesting because I was thinking about when I did graduate school a couple of years ago, crisis mental health wasn't a thing. And I think that that's really important to kind of remind folks who both work in the field and then folks that I see Phil kind of, nodding along, because when we were going through graduate school 15, 20 years ago, right, like crisis mental health didn't exist, right? What it was you would go through your treatment and assessment class and they would say, okay, if someone says suicide, give them the 1-800 number. That was it. Like, that was what we had. And so this whole concept and this whole movement has evolved kind of, it's what crisis mental health to me represents. And I was just at the suicidology conference that the American Association had done in Portland, Oregon last month. And one of the keynote speakers that was there pointed out that even as a field, suicidology didn't really get rolling until about 1965, right? And which is astonishing to think about. Like, it wasn't something that we were talking about or trying to figure out. And now it's starting to pick up steam. And when you look at even the behavioral health staffing that we have in Volunteers of America, we've increased 450% over the last 2 years. We went from a staff of roughly, at one point we had about probably 40 staff, and now we're knocking at the door of 300, right? And that's because of the evolution of what we now know as this whole concept of crisis mental health, which is, I would like to add, a ground-up consumer experience-based development, which is radically different than a lot of other types of behavioral health that we have. So from a clinical perspective, it's really exciting because it has inherently a lot more creativity, because it's based not on what we think theoretically might help, but it's based on what we know was effective, and it's based on the experiences of consumers who have needed the help in real time, whether we're talking about veterans, whether we're talking about the elderly, whether we're talking about kiddos in high schools, right? Like, it is based on the experience of the consumer. And one of the most exciting things to me is that we're finally including BIPOC communities in this conversation, because that was another area that was not being talked about even 5 years ago, right? It just wasn't being talked about. And so it's amazing to be able to see all of these evolutions start to happen. And, I'm excited to see where we go from here, because I feel like there's a lot of potential even looking around this room and listening to these conversations. Right? There's a lot of ways in which we're thinking outside the box that wouldn't have been possible 5 years ago.
Hey, I'm sorry. I wanted to piggyback on something that Keith was talking about when he was talking about what we're trying, and it feels self-serving because we're talking about all these different things, but I felt like it was important to put a point on it when he said about if we have a bed, if we have a detox, if we have an inpatient bed, we don't give a crap. If we don't have a bed, I find beds. Okay, I've driven people out to Jotzi in Yakima. Or the Lacey for South Sound, I don't care. The reason I took the job is because I asked in the very beginning, I said, is this about buffing KRC's numbers? And Keith told me, he said, I don't care how you do it, just help people. And that's why I took the job, actually. And also, he mentioned, the mouse maze that it can be to try to get people into Provider One services or Medicaid. I'm also now a navigator. I actually went through the training to become a navigator, so I can actually help with that as well. So what we're trying to do is we're trying to fix every crack, right? Close every gap, so that when we say, oh, but this is a thing, and we go, oh, I'm sorry, better luck next time. We don't want anyone walking away from a contact with us without finding a solution of some sort, and that involves getting all of you involved as well. I spend half of my days, because we're just getting started. But I spend most of my days reaching out to everybody, people in this room and outside of it, to set up meetings so I can introduce our program. And I get pushback, and someone says, well, if you meet with the HIN program, maybe they'll only send you one person a year. And like I said, one person, that's one more person. That's 100% more than I had from that resource prior. Right? I don't care how it manifests. I don't care where it comes from. Part of the thing, I've been working in human services in Kitsap County for a minute, and there's been a whole lot of, this is my clients and the thing, and this is garbage thinking. Yeah. Human services, we're part of a team, every single one of us, and there shouldn't be any, well, if we keep it in-house and all of that stuff, none of that matters or should matter from a very human perspective. Right? If I don't have the resource, I will hand you off to someone who does, and I will follow up too to make sure that it happens. Okay? Because I do that as well.
And not a month later. We're talking about the same day.
Yeah.
An hour.
Absolutely.
We'll get you help.
Yeah. And again, and people go, Curtis, you know a lot of stuff. No, Curtis doesn't know a lot of stuff. I'm functionally disabled. But in a way, sort of. I mean, but I know a lot of really smart people. And when you say, hey, I've got this need, I go, oh, I don't know, but man, I got a guy I can call, right? And that's where we all need to. I mean, I've talked with a few of you today, and I've given you my number, and I expect phone calls, like, because if you're not able to serve them, and I can cover in some way, you have to call me, right? It's your duty. If you think that I might be able to help, you have to, and trust and believe. If I know you, and I know what you do, and my client needs you, I'm calling you. Boom. I'll find out your address and come to your house. Hey, what's up, man? We're actually I just have a quick question. Just want to think of thing. I don't actually stalk people, but understand that the energy's there, man. My work cell is with me all the time, and I'm not allowed to work 24/7 because I'm just one person in the team. But man, I respond to texts and stuff because I care, right? My clients don't just find needs from 8 in the morning until 4 o'clock in the afternoon, unfortunately. And I'm super sensitive to that, right? So yeah, we're already talking about expanding my program and stuff because it's working again. So yeah, thank you guys for everything that you guys do.
Hi, my name is Josh. I manage crisis services for the Coffee Oasis. We're a youth-based organization and community. Kind of piggybacking off what you said, the biggest thing that challenges us is funding. The unfortunate part about all of our programs is we need funding. A lot of that comes from state funding grants, county funding grants. The problem there is that we create barriers. A lot of the grants that we get funded by are funded through the unduplicated numbers of people that we serve rather than the number of people we serve. I have, year to date, a crisis text line that's taken over 65,000 texts from kids in this county. That's from 1,400 youth. But they only look at the number of unduplicated. They don't look at the amount of services that we're providing to those youth, or even anybody in general. And that's a big barrier because that's 65,000 times that nobody is going to the hospital, or 65,000 times that I'm de-escalating a kid that wants to kill themselves. So there's significant barriers to services and getting funding, not just the resources that we have.
Thank you for the comment on just the idea of innovation, outside the box thinking. I mean, if we want to talk about what needs to get better, what can be better, I think this idea of outside the box thinking is one of those areas, and we need to bring in people with this creativity. We all know it takes time to get programs set up that essentially meet these unmet community needs, so we need people to think creatively and find other ways to kind of triage the needs. I mean, if we know that a number of factors go into why someone would consider suicide. So what are the other areas that we can do to meet these unmet needs? I mean, if it's going to take someone, unfortunately, too much time, at least for them, to sometimes get services, what can we do? Where can they go? Is there, is this a matter of mitigating social isolation? Is this, they're getting swamped by bills, they don't know where to go, and they just need someone to kind of help dig them out. It's finding whatever area we can to meet one or two needs, to at least try to lessen that, lighten their load a little bit. So really, thank you for that comment.
Hello, I'm Mary D, and this is Regina Avery. We're the reentry coordinators at the Kitsap County Jail. We work with people, trying to get them in services while they're in custody, basically. So we do referrals for assessments, for mental health treatment. The jail itself actually has a provider that takes care of mental health and medical needs, and we have a MAP program that people can get started on while in custody. We meet with the people that ask for our help, and when we connect them with the services, then we try to coordinate care. We do a little bit, I guess, case management per se while they're in custody, and if they're working with an agency, we'll set up appointments with that agency for when they're getting out. But I think there's a lot of stigma just around people coming out of jail or people who have been incarcerated, and there's a lot that want to get better, and if they're connected, and you guys sound like you're doing your part, so that's all.
Hi, I'm Dennis Herzog, president with NAMI of Kitsap County, and I've just heard everyone go around the room and watch the microphone go around, and a lot of anxiety here. But just want to say we do have programs for families, we do have programs for peers, we do have programs for veterans. So a lot of people out there are suffering now. Come down our table at the end here, pick up some literature. People don't have to suffer. We're a nonprofit, so we have a very limited budget too. But we're here in the community. We've been here for a while. We're rebuilding since COVID, but we're here. We want to help. We're here to serve. Come check us out and see what we can do. All right, thank you.
I'm Deanne Jackson, and I coordinate 2 of the substance abuse prevention coalitions in Kitsap County. And I think a lot has been said here, and I think the first steps we've said, but we really haven't articulated what they are. And I think those first steps are, it does say don't silo. We are the fabric that makes this community. It doesn't matter what sector we come from. It doesn't matter if we have been personally firsthand touched by suicide or mental health or addiction or poverty or any of the other things that plague our community. The reality is we're in this together as a community. So working together, stepping outside your box to work with the other partners in the community. We've all got some doors that are open, but we all need to enter them back and forth and welcome others into ours. If we are all working together 100%, I think will make the difference that needs to be made.
One thing that I just thought of, too, is we do all the work, we have the ideas, we don't have all the resources, and so I just wanna ask, and I ask from a place thinking about NAMI Kitsap, because I serve on the board for NAMI Pierce County, what are we doing to advocate and get that, our voices, because we do the direct services, what are we doing at the state level? Are we, I'm not asking, so don't raise your hands, are we attending events like this regularly? Are we a part of a board that supports mental health? Are we lobbying with our legislators? Are we writing letters? Are we, for every little case or thing that you see, if it hits you and it impacts you, shoot them an email, shoot them a letter. I know it takes time, you guys, but if we're not doing some of that lobbying and giving them the direct voice and the things that we're seeing, we are not going to get the funding, and we're not gonna get it in the areas that we need. They will allocate it and they will designate it and they will direct us to how it's used. And so I think it's really, really important, because we're doing the work, that we're doing that direct service in terms of reaching out to them as well, so they do know firsthand.
Rachel, one of the things that I wanted to piggyback off of was talking about stigma. She was talking about stigma of people that are coming out of incarceration. One of the other things that I wanted to talk about was stigma of people that are experiencing, mental health issues as well as substance use disorder all throughout the county, whether it's while they're receiving medical services or if they're just interacting with people that are out in the community. I know that personally, as a recovering addict, I have had many times where when I was interacting with medical professionals, I was stigmatized, and I was treated differently because of my past and the things that I've been through, and I'm treated like I'm a bad person rather than a person that needed help. And so I think that a lot of times people that are suffering from, mental health issues as well as substance use disorder, they're being stigmatized, and there needs to be more education to the community so that we can help them rather than, treat them as if they're bad.
Thanks. Hi, my name is Natasha. I'm a Washington State Parent Ambassador peer outreach worker, and the water I usually swim in is early learning, but I'm listening to the things that you're saying and about tearing down silos and funding and such. So the first thing that comes to mind is that the silos even between industries or whatever you want to call us, right? We're all serving families, and that something I say often is that we have to stop making people broken in order to receive help. And allow families just to be families. I think about the protective factors quite often and how to build them in community. And one of those things would be for an organization of mental health to be connecting with an organization that provides comprehensive early learning, quality early learning services. And so that was why I came, was to try to find out more about you guys. But I just want to end by saying a very close friend of mine, I was actually supposed to come with her, but she was sick, and I won't begin to tell you what she does. She works for Kitsap Strong, but she often says, community is a verb. And so I just would like to, just bring those thoughts up in that to unsilo, for instance, lots of early learning families are connected to the juvenile justice system, especially when you look at like ECAP or Head Start families. So, I just wanted to bring that. Thanks.
Thank you for adding that. I think that is a major disconnect we have, is between providers, between populations, being able, HIPAA, FERPA, everything contributes to the lack of ability for us to communicate and collaborate effectively. And in that, we forget about what we're really trying to do is service our clients and meeting their needs. And sometimes we think we know more than the person that we're serving. And we already have a list in our head what we're gonna do before we even meet that client. Or we got a call and we're like, oh, they're suicidal. Okay, they're saying this, this, and this. And so then we forget that they're human. We forget that their basic needs we're not even addressing because we want to protect ourselves from liability as clinicians. I think the one thing we forget is asking, what do you need today?
Yes.
What do I need today? Because the majority of us cannot answer that question. Even myself as a clinician cannot answer that question. And so we're wanting to come together as a community. We're wanting to support the community, but yet even as humans, we can't even ask each other. We can't even actively listen to each other. So how do we expect us to have this conversation and move forward to actually make a difference, to actually have a conversation, to know the resources that are out there when we can't even do it together? And so I love that you're going out in the field. I respond to kids that are jumping off bridges at times. Okay? I'm responding to bathrooms that kids are cutting themselves. I'm meeting them where they're at, not what I need, but what the kid needs, what their family needs. And I will connect them and wrap around them, even if I don't have the capacity to do so, because they need somebody. We all need somebody. And that's what we're trying to do as this coalition, is really going against and out of the ordinary and trying to develop something exciting and new and pushing up against stakeholders and funding and figuring this out of what can we do to make our community better and to not lose any more people. I've lost one of my students from a fentanyl overdose. I'm fully aware of what's going on outside and inside our school buildings and our jails. I am fully aware that we are in crisis and what we're doing right now is not working. It is actually harming. We can pretend it's working. We can pretend that to have this conversation. It's not working. So I think the next question is, what do we do differently? What do we need to do? What is in our capacity to do that we're not bound and held back by insurance companies, by funding, by all these things that we're bound back by and turning away people? I think that's the biggest question, is what can we actually do moving forward? Because we can go back and forth all day long. And there is people losing their lives. There are people struggling. We don't have enough beds for inpatient. We don't have enough therapists. We don't have enough detox centers. We don't have enough homes that people can actually afford. Heck, I'm a 2-income home, and it is hard to live in Washington State, and people continue to raise taxes and make it more difficult. And yet we expect those that can't navigate the system. I have my own child that can't even navigate the system. We have policyholders make these changes without even consulting the people that are doing the work. Who at 13 thinks that your 13-year-old should be able to make a whole bunch of choices for themselves and know it's in their best interest? Do I think in some instances it's great? Yes. But others, it's really hard.
Yeah.
So I think trying to figure out what's our next steps. And I want to do this more. I want to have more of a conversation. I think everybody was afraid of, oh my goodness, we have a panel member. They're all experts. I am no expert. I am just like you. I just have credentials behind my name. Okay? I struggle with anxiety. I struggle with mental health. And I see my own therapist. What? A therapist sees their own therapist? And I'm going to be vulnerable about that. I'm giving you guys permission to do the same. It's okay. It's okay to be who you are and be human, because being human is hard. And trying to meet each other where we're at. So really, we got to start with each other. Basic needs. Ask each other, how are you doing today? And actively listen. Not just listen with your ears. Actively hear people out, because we forget to do that as humans. Anybody have anything they want to add to that?
I just quickly wanted to add on to what Natasha said and some things that you were pointing out, and I think it's a great point that maybe we need to add this circle, because a lot of the people here are focused just on mental health, but like you said, access to childcare, quality childcare, is mental health treatment. If I'm a mother and I'm struggling with my own mental health, I need to know that my child has a safe place to go to while I'm taking care of me. I need to have access to housing. I need to have access to transportation so I can get to appointments. So these are all things that are mental health care. And all the people that you are interacting with are also interacting with these type of services, with schools, with housing, with accessing food, transportation. So I think that although someone might not see themselves as a mental health professional or specifically treating mental health, they are also a part of all of these people's journey, and I think that they need to be a part of this circle too. Can I add? I'm sorry, I'll give it right to that.
Don't apologize.
Okay.
You're just fine.
Thanks.
I wanted to say, probably many of you don't realize that a law was recently passed, and parents are now eligible for child care subsidy if they have any type of intervention. Mostly, I think they're looking at like incarceration or CPS, but I would encourage you to look into that and advocate for parents to get childcare while they are receiving mental health services, medical services, and treatment.
Which law is that?
Will you?
I can find out on my phone.
So in 2012, the American Association of Pediatrics has set a standard that pediatricians do an ACEs screening for all their patients. This is 2012. And so far, the most leading doctor that's doing this is Nadine Harris, who wrote The Deepest Well. How are we holding our pediatricians accountable to following a standard set by their governing board?
I will gladly pass the mic to the next speaker.
Your question's how we are addressing pediatricians? We're not, okay?
We're not.
There is a disconnect. I'm not gonna lie. I'm not gonna say, I mean, I worked in a hospital, I was an ER trauma social worker. I know that some of our pediatricians are diagnosing when they probably shouldn't, or they're not fully aware. And that same goes with some of our psychiatrists. I mean, we can be sometimes forward heavy on medication management instead of actually looking at interventions to provide. And so we're not doing that. And there's so many great questions of things that I would love to do, and that's what we're trying, and that's why we need you guys to wrap around us and not just these kind of events to figure out how do we hit every single population. Like, I know a lot of people, but I don't know everybody. And so it's like we really have to do this together.
Would it be, I mean, just a thought, outward thinking, would it be of interest, and it's just something to ponder and maybe send back to Andy, would it be of interest to gather people of, different stakeholders within this group to make an appointment, because you can make an appointment with your legislators and all go up and have a real honest conversation like we're having here. I know they were supposed to be here. They've come in the past. We know who our biggest supporters around these topics are, and if you don't, come talk to us because we know. But would it be something that there would be interest in, to go and actually go and sit and have this conversation with them, because they don't know what they don't know. So it's just something to think about, because they will take appointments.
Yeah, I was gonna say, so my position with VA Rep actually is I am the National Legislative Co-Chair. So most of our work is done federally, but I would strongly encourage, to form that legislative group and for you guys to come with your specific asks and talking about all of this, but go in with specific asks and what you're looking for. And I will say legislation can be the most frustrating thing ever. I scream, I cry, I stomp my feet, and then the next day I get up and I go again. And the biggest thing that I believe you can do, and the most powerful thing, and this is what I train my government affairs directors across the country, is to build the relationships with your legislators. Because when you build that relationship and you build that trust and they really get to know you, you will definitely get further along. So the other thing is never give up. We just had a bill introduced last week that we've been working on for 12 years. Okay, that's where I say it can be frustrating. But now we celebrate, but I said we could celebrate for a day because now we have to get it passed. Okay, so I said you can celebrate today, then we're done, let's go. But that would be my biggest thing is form a small, legislative committee out of this group. Come with your ask, but you guys build relationships with them. Go to their events. Go see them where they are. Let them see you out at all the things because they build that trust with you. And honestly, that is how you get crap done.
Okay, you guys, we only have about 10 more minutes left, so I have a few more comments and then we'll close out soon.
Quick comment for those of you here that cannot lobby in your positions, but you definitely want your voice heard. Learn about advocacy if you don't already. There is a difference. It is a fine line, but if you can't lobby, you can still advocate for change, and it does make things happen. So if you're not sure, talk to some of your partners, go online, learn about it. There's lots of great trainings that are YouTube videos and things like that that can walk you through it. But it is can be a dangerous line to walk, so it's important to know the difference. But it doesn't matter on what side of the line you stand on. You can have a voice for these policy changes. Every single one of us can have a voice.
Okay, as we're closing up, so if you guys don't know,
I can help.
we have an Instagram and Facebook page. It is under Kitsap Suicide Awareness Coalition. We meet every month. We have a conversation. We have a lot more stakeholders that are there. I have people from law enforcement to fire to everywhere and anywhere that are involved in those conversations. So if you are wanting to be more involved, I would love it. I'm only one person. We have a group of us that really do it, but we need all of you. We really do to make a difference. So again, please follow us on Instagram and Facebook, and I'd love to have more conversations like this and not having to just make an event for it, because really all of us are very passionate and vulnerable and wanting to make a change. So any other questions, statements?
Andy, I just want to say also for those of you who are here that may be struggling with mental illness, you're welcome to come to that group as well. We need to hear from you. We need to see where you're having struggles with on a daily basis. How are you getting into service? How are you accessing? What's the gaps for you of reaching help? Why are you not connecting with the providers that are out there? Let us know. That is a safe forum for you to be, and we are not there because we're better than you. We're not there because we're more educated than you. We are there because we are you. Each one of us. We have some kind of reason why we got in this field, and it wasn't because we've all had easy lives. So I want to invite you all to be part of that group, let your voice be heard, and join us to make this world better. So thank you for coming.
All right, you guys, if you guys want to go look at the booths, and then you guys can head out. Do we have somebody, Philip?
I just want to say thanks for organizing this. This takes a lot.
It's good to come here.
Y'all do an amazing job.
Where are you from?
You are from the
community? Oh, yeah? What do you do?
I'm a healthcare worker.
Oh, good.
So I work in hospitals and all that medical things.
Yeah, I'm Heather. I work up at the high school, so I'm a counselor. And
Birmingham?
I'm South,
okay.
but I know all the Birmingham counselors, and yeah, I used to be counseling school. But school school counseling for, I don't know, like 16 years now, but I sit on a panel called West Elm Counselors. So all of us counselors, including Bremerton, Bahia, everybody in the area, we get together and kind of have round conversations about like stuff like this as well. Yeah, just trying to figure out how to meet the needs for us. It's for youth, obviously, youth and families. But, so yeah. So what do you do in the medical field?
I'm a phlebotomist.
Yeah, so I'm sure you.
I deal with my own mental health, anxiety, having to deal with patients and all that, and their anxiety and what they're going through.
It's a lot.
And I work